Welcome to Conceive the Podcast, your resource for all things fertility, women's health and pregnancy, with your hosts, Jaya Ferreira, Chinese medicine practitioner and Director of Natural Fertility Geelong, and me, Libby Morgan, Practice Manager and Jaya's friend.
Welcome everyone to our first episode for Endometriosis Awareness Month. We wanted to kick off this month with chatting with Obstetrician Gynaecologist Dr. Marilla Druitt. Marilla is one busy specialist and we are so grateful to have her time today. Not only is she an obstetrician gynaecologist at Avonlea Clinic in Geelong and St John of God Hospital, she also holds a public appointment at Barwon Health in both pregnancy care and those with complicated substance use, along with pelvic pain, endometriosis and minimal invasive surgery. Marilla is a gynaecologist at the Persistent Pelvic Pain Clinic in Geelong and one of the co-investigators of the HAPPY study, which is examining the effectiveness of mind-body interventions for people with endometriosis and pelvic pain. Marilla is a senior lecturer at Deakin University, one of the contributors of the Endometriosis Guidelines of Australia, and a RANZCOG counsellor. Welcome, Marilla.
Welcome.
Thanks for having me.
Okay, so we're going to be talking about endometriosis and pelvic pain. But first, let's talk a little bit about your background. Did you always want to do medicine?
No, actually in year 11, I thought I was going to do music therapy.
Oh, wow.
I did some work experience in that and that was pretty overwhelming and difficult. So medicine seemed to be a good fit for me. But I've always been interested in things that are more than the biomedical approach to getting people well, which include things like music and a holistic view of health.
Beautiful. Okay, let's give a brief overview of endo for people that don't quite understand what the condition is. And maybe you can just explain how common it is.
So endometriosis is where the lining, similar to the lining in the uterus, is now somewhere else. And so most commonly that's in the pelvis, but occasionally it can be under the diaphragm, up near your chest. It's been found in lungs and your nose and all sorts of other places. And so it's primarily a condition of women, but really anybody who has a uterus and ovaries can have it. It's been found in men. So there are lots of theories to explain why it might happen, which can involve retrograde menstruation, or when you have your period, about 90% comes out the vagina, about 10% spills out your tubes into your belly. And so maybe it happens in that fashion. But any cell in the body can change, which might explain those other presentations. And from our latest data, from a group in Queensland and the Australian Longitudinal Women's Health Study, it's estimated that 1 in 9 women between the ages of 18 and 44 have had a diagnosis of endo in Australia, which is quite a lot.
And how is it diagnosed?
Our gold standard is a laparoscopy, keyhole surgery, which involves little cuts in the belly, filling your belly up with gas and inspecting with a camera all of the surfaces that line the pelvis. So this is obviously a pretty invasive way of finding out does somebody have something or not. The second way, which is a very good screen but not a diagnosis, so it doesn't give us a yes-no answer, it just really ups your likelihood, is really good imaging. So imaging with an ultrasound or with someone who's been trained in deep endometriosis ultrasound or MRI, and also with our new national guidelines, I could see that CT is also really pretty good. But in Australia, we don't have people who are used to looking for it on CT. But around the world, other people use different modalities.
And I would say clinically, I don't really see MRI performed often. Is it something that's commonly done?
Well, it depends on where you are. In tertiary centres, often they will have an MDM set up, so a group of different specialists who will look at the ultrasound findings, the MRI findings, the surgical findings, that sort of approach. But in Australia, we don't have MRI funded, but there's no rebate with the MBS or a women with pelvic pain looking for endo. So if it's going to cost $400, $600, then that's not a realistic option for people at the moment.
More likely go to ultrasound first.
Yeah. Ultrasound's a good start. Absolutely.
And there's a differentiation in types of ultrasounds that you can get. Is that correct?
It's the set of eyes that are interpreting the ultrasound as they go.
I see. Yeah.
Yeah. So our gold standard probably these days is a doctor who has done O&G, who has done ultrasound subspecialty training, and then has gone on to do further training in looking for deep endometriosis at ultrasound. And so we've got a handful of them around the place. And a lot of them have been over to Brazil, actually, because half the poor Brazilians seem to have endo. And so they've pioneered the use of
interesting.
ultrasound looking for deep endo. And deep endo is sort of bowel nodules, big bits, so more than 1 or 2 centimetres that you can see as a discrete lesion sticking one thing to another.
Yeah, and that's a really important aspect to highlight, looking for an ultrasound clinic that specialises in that area rather than a clinic that's doing everything.
Yeah, sure. So if someone's got pain, I think that they should know that if you're going to bother having a probe in your vagina, you may as well get your best
100%.
information from that experience. But, it takes a long time. And again, if it's not, if it takes 45 minutes and sometimes you need bowel prep, like that's a lot of time and effort. And a lot of places don't have the resources to be able to fund that sort of thing.
Yeah, comes back to the funding, doesn't it?
Yeah, often we get the impression that CT and MRI in lots of radiology places are the ones that are sort of helping to subsidise the pelvic ultrasounds.
And from a fertility perspective, what do women need to know about endometriosis and how it can affect their fertility?
Sure. So we've got some good trials looking at treating endo, but essentially we know that it's a risk factor for a delay in getting pregnant, but it doesn't seem to be a risk factor for everybody. And the amount that have doesn't seem to correlate particularly well with how much subfertility you might have. So subfertility is, a couple's trying to get pregnant, and about 85% of couples will conceive within the first 12 months of trying. And in the group who then are taking longer than 12 months, maybe a third of the time the woman may have some endo. So then the issue is how much does that endo contribute to that couple's subfertility issue? And for different people, it probably matters to a different extent.
It's weighing up the risk.
Yeah, so a risk factor doesn't mean that you're going to get the thing.
Yeah.
So endo's a risk factor for pain, endo's a risk factor for subfertility, but it doesn't mean it's going to be for you.
Yes. Okay. So women who are trying to conceive and are struggling and are potentially presenting with symptoms of endo.
So, yeah, that's a good question. You don't need to have pain to have endo associated with subfertility. So you might have no pain, but you can have endo, and treating that endo might increase your chance of spontaneous conception.
We know on some level it may affect fertility, but
to what degree, we don't know. Yeah.
We don't know yet.
Yeah, so there's lots of, careful algorithms of, you've got this risk factor, that other risk factor, this is how old you are, this is how long you've been trying for, this is maybe the amount that we saw at the laparoscopy, and you put it all together and try and get a gauge of what impact it might have or what the treatment impact might be. So it's one of the many variables that should be taken into account.
Makes the job a bit tricky for the specialist too.
Yeah, but that's what makes it interesting, right? And people are not straightforward. Like nobody's straightforward in any respect for any health issue.
No.
They always have a million variables that matter, and so we have to work out what we think might be contributing, but also what the person might care about.
Yeah, absolutely. Let's talk about the language around pain. So from our initial conversation, one thing that really stuck out for me was that you said that pain education and understanding the neuroscience of pain is such an important tool. Can you talk about why the brain is such a big influence on pain associated with endometriosis?
Yeah, wow. So people have done the whole PhDs on this, Jaya. So in 10
summary.
words or less, radio.
But yes, I know it's a massive topic.
So pain is a sensory and emotional experience associated with or, potential or actual tissue damage. So, you can have pain if you've got no arm, phantom limb pain. You can have pain when you chop your leg off. You can have pain after you chopped your leg off, 5 hours ago because it wasn't appropriate to have pain then. So, the brain is amazing at judging, do I need to make a symptom now to get myself out of danger? So you can have signals coming in from the periphery, such as, the chemicals that endometriosis makes, or maybe the mechanical obstructions associated with adhesions or scarring. And have signals coming in from a bladder that's filling up. And in the opposite direction, streaming down from your brain are lots and lots of nerves which are trying to modulate that signal. And then all of this relays at a whole variety of levels, up from your uterus, for example, to your brain, to your brainstem and your thalamus. And then your brain has to decide based on everything that's ever happened to you, plus probably genetics from your parents and the bugs in your gut, and are you having a good hair day or not? Should you make pain to get yourself out of danger? Or who cares that your bladder's filling up? It's not about to pop. You're in a meeting, ignore, don't make a symptom. Or got PTSD, there's been past trauma. You know, you need to absolutely respond to any last little signal that's coming from your pelvis, because that might represent danger, and you should make pain to get yourself out of trouble. So endometriosis is interesting in that it's just another peripheral driver. But there was some amazing brain research done by Susie Asani, who's a gynae in America, and that's published about 10 years ago. And she looked at the brains of women with endo and pelvic pain, and the women had pelvic pain and no endo, and the women with endo had different brains. So,
Wow.
you know, maybe this thing in your pelvis is a marker for some process that's happening in your brain.
That is so interesting.
It's amazing. Yeah. So, you know, the point there is everything matters, right?
Not just the endo, but the woman itself.
Yeah. All of those variables will matter, which might then be able to explain why sometimes people have horrible endo in terms of late, you know, a decent amount of it. So stage 4, deep endo, everything stuck to everything else. And she's having her tubes tied because she doesn't want any more babies, but actually she's had no fertility problems and no pain problem.
That's an important thing to talk about as well, that there are women suffering with pelvic pain that don't have endo.
Sure. And there are a gazillion times more of them than those who do have endo. And although I think that this, you know, this advocacy work that has been amazing over the last, you know, 10, 15, 20 years, that has made things progress so much faster than if, you know, healthcare people have been trying to just do it alone. That's been wonderful for now everybody knows what endo is, and the government's got this national action plan and funding is improving, all that sort of stuff. If we are only caring about the women with endo and pelvic pain, that also is that's selling the wrong message, and that's not getting us any further. So I think, yes, it's important to know about a disease process that we can see, that we can biopsy, that we can look at under a microscope. Really, in the end, I want people to be well and have no symptoms. And so the ones who don't have endo, who have all of those symptoms also, of course we should be looking after them. So they always need to be part of this conversation. And sometimes I have patients who don't have endo at their laparoscopy and they feel so terrible, as if now people will think that they were making everything up, which obviously is ridiculous. But,
Yeah.
you know, if you're not in the gang, not in the, you know, the current group who has got a voice, that can compound the injustice of this whole problem.
Yeah, absolutely.
So we should, you know, make sure that everyone's symptoms are better.
Yeah. And
'Cause
pain is
often-
pain.
Sure, absolutely. Yep. Your pain, I don't think we've got great evidence that your pain has to be worse if you've got endo than if you don't have endo.
No. And I think people feeling supported and heard and taken seriously with their pain symptoms.
Yeah, of course.
Let's talk about some of the non-surgical treatments or alternatives that will aim to reduce pain.
Yep. So when I see a patient, usually I end up drawing them a circle. And, you know, most people have got some way of trying to represent all of the things that are going on for people. So Susan Evans, who's the guru of pelvic pain, she's a pelvic pain specialist and gynaecologist. She was the one who started the Pelvic Pain Foundation. I had an absolute light bulb moment at a conference once when I saw her showing to some others who'd gone up after her lecture to ask about how she shows people, how she draws the diagram that everything matters. And so what she does is draw a brain and a spinal cord and the organs in the periphery and the way that they signal up to the brain, and then all the things that happen on a brain front to perhaps ignore those signals or modulate those signals so that then the output of the brain, i.e. pain, is less. So I always use that one for people, but I also draw them a circle, and then we talk about the component of uterus. So how much is your period pain contributing? How much is cyclic? So what proportion of your pain is mid-cycle or worse in the second half of the cycle? So often, like, you know, migraines and headaches and bloating and gut symptoms and IBS will be worse in the, you know, weeks 3 and 4 if someone's got a roughly 4-week cycle. What proportion might be endo? What proportion might be muscles, because there's a reflex of something happening in your tummy and then all of your muscles surrounding get tight and switched on and hurt. So that then can muck up your emptying. You can't do a wee properly, you can't do a poo properly, you can't put things in the vagina, it all hurts. So muscles matter. We don't know what proportion of someone's pain might be due to endo. we have tools for the uterine component, the ovarian component, the gut component, the bladder component, the muscle component, the brain component. Someone can see that it is not all a hormonally responsive, i.e. only hormonally treatable situation, and they might not choose to use those things, but it's just nice to know that there's 50,000 other things that we can do to improve their quality of life. Because if endo's only 1% of your problem, then maybe you don't need a laparoscopy at this stage, or you've already had one and we've got the diagnosis. Maybe you want to focus on your muscles next, or your mental health, because you can't fix pain first, mental health second. You've got to do it all together.
Absolutely. I think there's a common misconception that if you get rid of the endo, you won't be in pain anymore.
Sure. We would love to hope that. And for some people, actually, it does work. So they have a laparoscopy, they have their endo treated, and they are heaps better. And that is amazing. But one of the reasons I am interested in this situation or this community is because for lots of people that doesn't work. It's not enough. And so you can't just stop there.
So things like a women's health physio, very helpful.
Yep. They are absolute gold. And often I just feel like I'm a physiotherapy triage service when I see people. Say, your muscles are really sore, they're really tight. That's why you are having trouble emptying your bladder. That's why it really hurts to do a wee. That's why you can't do a poo properly. This is why it hurts when you have sex, or can't use tampons, or that ultrasound was really awful when you had an internal ultrasound. So pelvic floor physio is fantastic. So some of what they do is manual therapy, which is learning how to stretch out the tight sore muscles, focusing on breathing techniques which help remind the muscles and activate your parasympathetic nervous system with all of that vagal business. But some of it is brain stuff. Some of it is pain education. And so there was a really cool study done about 15 years ago in Adelaide by one of the rock gods of the pain world, Lorimer Moseley. And he looked at adults with back pain. And so one group was mechanics, ergonomics, here's how you pick things up, here's how to sort out your desk. The other group was, let's teach you about the neuroscience of pain. And the neuroscience group did better. So physios are really well placed to teach people about pain neuroscience, because when people learn stuff about their condition, it probably takes away some of the stress and fear and uncertainty, and there are probably lots of mechanisms for why it works, but pain education is a winner, and physios are well placed to be some of the people who teach people that.
It's probably important to highlight as well that a women's health physio has done extra training. It's not all physios.
Yeah, sure.
We've got some great ones in Geelong as well.
Yes, absolutely we do.
We
need more.
We need more, yes, we do. After talking to you as well, a psychologist that works in pain specifically can be beneficial.
Yes, absolutely.
Do you refer a lot to a pain psychologist?
Always. And from the beginning too, because what doesn't sit well is if, someone's had 3 laparoscopies and they worked a bit for pain for, 6 months, 12 months, that sort of idea. And then, after 5 years, then you say, do you want to do cognitive behavioural therapy with a pain psychologist? That's sending the wrong message. And it doesn't get taken well by people. They're mistrustful. So our job is to tell people from the beginning that all of these things matter, and I want you to do all of them now, which, is really time-consuming and it's hard work and it's not fair. It would be much nicer if you only had to do one thing. But, cognitive behavioural therapy with pain psychology, the pain psychologist, has been shown in our best level of evidence when we try and research stuff to be effective, an effective treatment for pain.
So the first consultation is really important of laying out the whole foundation, but actually getting the patient to understand what treatment plan will be.
Sure, but if I boss somebody into something that they don't want, or they, they're more likely for it to not work, or they're more likely to have side effects with that treatment. So I feel my job is to say, here are all the things you could do. You need to go away and have a think and work out what feels right, what sits well with your values, because that's going to work better than me telling you what to do anyway. So, it's easy if someone's got cancer and we say, absolutely, you have to do this. Why aren't you doing this? I'm going to try really hard to boss you into this treatment. Not if someone's 95 and they don't want it, but, we feel like we should advocate more strongly. But in this situation, if we've proven that nothing evil's going on that needs acute treatment, then we're going to have a more durable plan of action if we do that shared decision making and decide together that this seems to be the right plan for the moment.
You're working as a team. So you said before that a laparoscopy is the gold standard. In terms of the current research, do all women need a laparoscopy?
So what you're asking is, so you've got a woman with a set of symptoms or a person with a set of symptoms. We treat it with a variety of things. A scan might have said, possible chance of deep endo. If she's all better and she's not trying to conceive and she's never going to try and conceive, well, then maybe she doesn't need a laparoscopy.
And the pain's managed through other means.
I guess what I'm coming at as well is that I think a lot of women say it's there, it's inside of me, this condition, and it needs to go.
Sure, I hear that a lot. And, there is nothing that makes me happier than being in theatre operating on people. I love it. It's my happy place. But what happens if she's going to be the one that it doesn't help? So absolutely, that's our gold standard for diagnosis. Mm-hmm. That's how we tell. So you take a sample of the tissue, you send it off to pathology, and they can help us, they work out, is this endometriosis or not? So yes, it's important for a diagnosis. And for somebody who might have been dismissed for the last 10 years of, this period pain's normal, or, you've been on one pill, like, I don't know why you're not getting better, you just have to put up with it. That can be an affirming thing to have. A laparoscopy, yes, I did have endo, finally I'm, and I can take photos of myself and stick it on Instagram with me in a bed. And that sends the message that this was serious. It was serious enough to get me into hospital, to get me an operation. Please take me seriously.
It wasn't just in my head.
Absolutely. But what happens if the laparoscopy is not going to fix your pain? So people need to make a careful decision about that. But your original question is, can you have endo and can it stay there? Does it matter? If you're not trying to get pregnant and your symptoms are all better, I think it can stay there, with the exception of a cyst that we haven't confirmed what it is. So there has been discussion around the world for many, many years about whether or not endometriosis is associated with cancer. And so for the evidence-based guidelines that Australia has written, they have specifically said, no, it is not associated with cancer. Because people have this idea that if there's something in there, it has to come out.
Yes.
But same idea with back imaging and back pain. If you've got some terrible looking thing in your back that might be age-related changes, it doesn't necessarily need fixing. All of your symptoms have gone.
Yeah, absolutely. Okay, let's talk about some endo myths. So we've already covered this a little bit, but the amount of endometriosis you have doesn't directly correlate to the amount of pain you have.
No.
Does it?
Correct.
So I think a lot of people would say stage 4, it's the worst. I should be in the most pain. Or people are very confused about the fact that they're in so much pain and then their surgeon goes in there and doesn't find much endo.
Sure. So stage 1 and 2 is the sort of spray painted amount, superficial peritoneal endo. Stage 3, 4, big ovarian cyst, endometriosis in the cyst, or nodules of endo invading into the rectum or the lower part of the bowel. We would love to think that the more of something you had, the more symptoms you should have. But because the brain is so amazing, that probably is part of the reason why it doesn't seem to correlate that clearly.
Yeah.
What it does help us work out is how long might an operation take, and do we need the help of a bowel surgeon from the beginning rather than get in there and discover that it was way more than we were expecting. So it helps us prepare well. And so I don't think that anyone should really have a laparoscopy as a diagnostic procedure in a planned, not acute situation without having been offered really good imaging beforehand. Because if you have lots of endo everywhere and nobody was expecting it, then sometimes it's not appropriate to do it at that point. Have a look, you've diagnosed it, and you're not going to do any of the treatment at that stage. And so then you end up with 2 operations instead of 1.
Yeah.
And so, these vaginal ultrasounds or MRI that you pay for good endo images, they're not very easy to access, but it's not often that this is an emergency situation. And somebody might choose to not go and pursue or, travel 2,000 kilometres to go and get a scan, but at least they know it. Like, it's not up to us to decide, should I tell you that this exists or not?
Yeah, absolutely. Myth number 2, getting pregnant will help your endometriosis.
Well, it might make the lesions stop growing, or it might make the endometriosis regress, but it's all about symptoms, right? And so if your symptoms are fewer when you're pregnant, then good for you. But what are you going to do? Have 20 babies over the course of your reproductive life? It's not a great long-term plan.
It's not a cure.
No, it's not a cure. there was an interesting Italian study maybe 10 years ago, and it looked at mode of birth of, I've had all these operations, I've got endometriosis, should I have an operation to have my baby, i.e. a cesarean section, or should I have a vaginal birth? And it looked like pain was a bit less likely to recur in someone who'd had a vaginal birth. So, that was the first positive press that vaginal birth had for a while in the medical community. So we're all pretty happy with that. But these things are short-lived, and it's a chronic condition for some people. But it's a really heterogeneous condition for people. So one person's version is not necessarily the same as somebody else's that can regress by itself, or another that can progress and you didn't have any symptoms. Like it's a disease that we know a fair bit about. There's been lots published, particularly recently, but, there's heaps more work to be done.
And the pressure to have a baby shouldn't be added on top.
No, that's ridiculous. Women are not put on this earth to just reproduce. Like, that is not your reason to be.
No.
And also, so, it might be, it's something that we should talk about to say, okay, you have endometriosis. Do you want to have a baby in your lifetime? Is that on the cards for you? Is that something that matters a lot to you? Because if it is, your age is your best predictor of being able to conceive. Yes. And so if you've got endo, well, then get going now. But, that's easier said than done. Like, you need to find the person and you need to find the right time in your career with our public policy that is not so flash for maternity leave. There are many competing interests.
Yeah.
But we can't say go have a baby. That's just not right.
Number 3, pain relief or the pill is masking my endo. So some people might say the pain is getting worse and I wouldn't know about it. I hear it a lot is that the pill is masking pain.
Yes. So masking implies that there's something else progressing.
Yes.
I don't think we've got good evidence that that is necessarily the case. Apart from perhaps if you're running the pill in the traditional fashion of 3 weeks on, 1 week off, and in that week off, 10% of people will ovulate, which makes it not very good contraception. Plus you also bleed, which is a time where if you have an endometrioma, maybe your endometrioma gets larger. That's a possibility. I think that we should say treating. So I don't think that we've got really great evidence. And if someone is really worried about that, well, then they could just have a rescan. So, you have your treatment, it fixes your symptoms, have a rescan. If the scan looks exactly the same, well, then hooray for you.
Because I think there's a lot of women that are taking the pill and they feel better on it, they feel great, but then they feel guilty about that they feel like they're reliant on something or they don't want to be on something that's treating their pain, which from a psychological point of view, I think it's just creating more pressure on the woman.
Sure. So if we're going to talk about natural, then there is, one anthropological sort of theory based on a group of hunter-gatherers in Africa, and it was published maybe 20 years ago, and it looked at how many periods did the average woman have, 10,000 years ago, when there was no farming, no crops, no stable sort of food, nutrition was worse, et cetera, and a few numbers are bandied around, but maybe in that context, maybe a normal number of periods for your lifetime was about 150. And these days, teenagers manage to squeeze 150 into their teen years, and across your lifetime, you might have 450 or 500. So what we are doing now is not natural, and maybe, our physiology hasn't quite matched this, evolution and physiology hasn't been a particularly good match. And so this is great if you want to sell off your daughter to the next door farmer, hooray, she can have a baby. Or, people are impatient and they decide that they're going to go on leave and get pregnant and then go back to the work, in October and and we're controlling our lives. So that's great to have a monthly period for that reason. But absolutely there are trade-offs. And so lots of people have hormonally responsive pain problems. And, if it's not endo, it might be migraine or IBS or whatever. And so the more pain you have now, the more pain you have later. And so this natural provocation of your pain on a monthly basis actually might get you to a worse place. So it's good for conceiving, but there are absolute trade-offs to be had. And if you don't like those trade-offs, well, hooray, we've got some things to treat that.
Why are we having so many more periods now?
Well, because you don't get married when you're 14 and have 20 babies and breastfeed them all for 3 years, and then you breastfeed the next door neighbour, and then you're a grandmother and you relactate to help out your daughter who's just had this massive PPH and tried to die, you know. So we've got way more time that we are not reproducing. So hooray for having your license, going to school, not being at the, you know, mercy of your anatomy. But at the moment we can't have it all.
No.
You can't be natural for, you know, in many situations.
I work in the natural realm, but this whole driving force, it has to be one way or another. It just doesn't need to be that way. We need to drop the judgment around it.
But also a binary system for anything doesn't work particularly well apart from computer coding. Like
Exactly.
there are shades of grey, there's a spectrum of everything, and you've got to pick how you function the best and what you're prepared to trade.
And what's the best fit for you and your life?
Yeah. Weigh up all your options. Make a decision. Don't get, you know.
And what helps your pain?
And you don't have to do what your friend did
do.
or what you read on the internet. Is excisional surgery better than ablation?
All right, Jaya. Rightio.
Sorry, I'm hitting you with a tough one.
So I know that there is a lot of discussion out there in the patient advocacy groups.
Yes.
And so I think we've got, you know, maybe 3, 4, 5 randomized trials, which are the best way to test these sort of propositions, to say treating endo is better for pain than just looking at it. We don't have great trials to know what is the best way of doing that. So we've had 2 trials, as far as I am aware, including one that was done at the Royal Women's Hospital, looking at burning the lesion. So that's an ablation of the lesion or endometriosis versus excising it. And they couldn't demonstrate particularly convincingly that one was better than another for pain. What I would say is that mostly we think that if you treat it all at that first laparoscopy, that is better than you treat, you know, quarter now, quarter later, because repeated surgeries can get people into trouble too.
Yeah.
But no, I don't think we know that. I would like to think that, because that's how I trained, that if we cut out all of the endometriosis and it looks beautiful at the end, well then, hooray, it's all gone. But I have to go with my data, which does not strongly support that one is better than another.
Why do people feel like if they had ablation in the past and now their surgeon has done something different, that they had something wrong previously? Where did it get a bad rap?
I think with improved surgical training. So in the early days, and gynaes were some of the first to adopt laparoscopy, that was what we had available, and that was the skill set. And as skills have improved and knowledge of anatomy is vastly better than it was, and better equipment, so amazing equipment that can pick up very small amounts and finally excise it without injuring nearby structures like ureters. So our equipment has improved, our training has improved, and it's a nice concept to think that if you've taken something out, well, then it can't be there anymore.
Yeah, absolutely.
It sits well, but that visual imagery is powerful.
Next myth, you'll need a hysterectomy.
Well, need is an interesting verb. You might end up with one, what I would say. If your mechanism for endometriosis is that retrograde menstruation, then if you don't have a uterus, well, you can't get retrograde menstruation. But as we've previously established, the amount of endo doesn't correlate with the amount of pain. And so all a hysterectomy can be guaranteed to do is stop your periods. And the more pain someone has before a hysterectomy, the less likely the hysterectomy is to fix their pain. So there have been some interesting trials looking at central sensitization or measures of chronic pain. So, you know, it stopped being about what's in the periphery and now it's mostly in your brain, and it's a brain condition. And so some trials for hysterectomy have looked at a fibromyalgia score, and if you score high on the fibromyalgia score, it's a marker of central sensitization / chronic pain / brain thing, then about 25% of the people who have a hysterectomy do not benefit from a pain point of view.
Wow.
So, but, you know, 3/4 do. And for some people, if they're flooding and they can't leave home and they have to plan to be at home for, you know, 3 days a month because they make a huge big mess and they can't wear any clothes, and, you know, it can be so disrupting for your life.
Absolutely.
If they've tried all of their hormones, or they didn't want their hormones, or they couldn't have the hormones, then, you know, hooray for them not having this massive, you know, problem for their function. But again, you know, if we do some prehab, hopefully we don't have to do so much rehab. So if we can do lots of things to make pain better before an operation, people recover faster and they are way more likely to benefit from that operation, rather than let's do the operation first and then do all the other stuff last, you know, secondary.
Doing all of that
secondarily.
beforehand. Yeah, okay, that makes sense. That makes a lot of sense. think we've covered this a little bit, but there is a preconceived idea that once you have endo, you'll always have it and that you'll continually need to have laps in the future.
For some people, that turns out to be the case.
Yes.
But for some of our research studies, second look laps, some endo had regressed. And that's without treatment. So it's not a done deal. Again, it's a heterogeneous condition. Like, not everyone's ulcerative colitis is the same.
Yeah.
Not everyone's knee osteoarthritis is the same. Everyone can be different. So absolutely, there are groups who have one lap and they're fine and they go off and are happily ever after. That's wonderful. And we would dearly love to have some sort of prediction tool to help us work out who's going to be in which group, and then we can tailor their treatment appropriately. Maybe, we can do this again in 10 years and I can tell you.
And the last one, took my doctor 8 years to diagnose my endo. It should have been earlier. This length to diagnosis is quite big in social media and I guess in a lot of support groups as well. Do you think it's a big problem, the length to diagnosis?
I think it's a really helpful way of pointing out deficiencies in our health treatment. It's a catchy way to explain the length of suffering. So it's good from that point of view. Certainly it's decreased in Australia since people have started to measure it.
Yes.
So that's good. And, I'm delighted that now lots of people know what endometriosis is and previously they didn't. So we've come a massively long way, and partly because of ways of communicating health statistics like that. So that's been really good. But I'm not sure, again, if it was the endometriosis diagnosis that mattered. What was the problem is that she didn't have her symptoms fixed, within the first 12, 24 months. That's the problem. So this sense of injustice is a risk factor for chronic pain. And until we can turn it around a little bit and say, actually, it was that my symptoms weren't fixed. Because, having symptoms for 6 years, that's not okay. That's not on.
No.
We've got plenty of treatments and we've known for quite a long time what they can be. It's just that our health service is not particularly set up to provide them. So we should have fixed her symptoms early. Whether or not she had, and then maybe it wouldn't have mattered if she had endo or not.
Especially if she didn't want a baby.
Exactly. So does the length of time to diagnosis matter? Yes, in that it's a marker of didn't fix the problem, didn't fix the symptoms early. But, you will get other opinions on that, obviously. So you need to interview someone else who does, who feels very strongly the opposite.
Yes, we have.
Good. Excellent.
How do you think COVID has impacted access to care for endometriosis and pelvic pain?
So in the beginning of 2020, when I hadn't done any telehealth, I was quite scared that it would be a complete schmozzle and that it was all going to be a disaster. And then as things went on, we realised more and more how much stuff we can do over the telephone or over video. And so, sure, it decimated our gynae operating lists and we couldn't offer people the laparoscopies to diagnose and treat. But people are inventive and clever, and this group is so motivated that people then could see other things that they could do. And, there was a lovely paper published by Mike Armour, who's a complementary medicine practitioner who does lots of Cochrane research in Sydney. He and some collaborators wrote about all of the things that you can do in lockdowns, in COVID, that don't have anything to do with being in a theatre.
Amazing.
So that was sort of good, because then the rest of the stuff that you can do that is not surgery got way more press than it ordinarily would have. So yes, there were lots of people who probably would have benefited from a laparoscopy who missed out, but the silver lining was, well, now let's think about all the other things that you can do. And often we are trying to be the champions or the commitment devices or the coaches to help people do the stuff that we know can help them. So getting people exercising, because exercising is so good for pain and really good for pelvic pain. Learning about meditation and psychology treatment, which was, fantastic over COVID if you could get in to see someone. People like Meg Odgers, who's one of the pelvic pain psychologists that I work with on the Happy Study, she then made us this 2-page list of a gazillion resources of things that people can learn, pain education websites and free courses that the government had subsidised for cognitive behavioural therapy online.
Excellent.
So, for some people, that was their prompt to do it all themselves with a bit of coaching over the phone. So, COVID was it. But a few silver linings of now I can do this thing myself. It doesn't all have to be about what the doctor can do for me. So I saw some
really
real
important
success stories. Yeah.
Oh, that's so good to hear. What are some of the resources in Geelong in Australia that people might need to know about just for support in endometriosis?
Sure. So having a geographically located advocacy group or being a part of a community can be fantastic. They are, many and varied, and it's a bit like, what sort of yoga do you like? You need to go and try before you buy and work out what group works for you. Is it moderated for someone to do some fact checking? Is it all about learning? Is it about supporting each other with stories, or does it sometimes deteriorate into, people who are really, really unwell, who are not getting support through any other mechanism, and then that can become a not very helpful thing. So those sort of resources are wonderful, and I work with Endo Help Foundation, which is one of the Victorian group. In Geelong, there's Talking Endo, which is a monthly webinar series. It used to be face-to-face. Those days are gone. But actually now heaps more accessible for people who live in the middle of nowhere. So
We'll link
hooray.
these resources.
Yep. So Endo Help Foundation, Talking Endo, which is a monthly webinar series that Kat Stanley runs. We have the Happy Study at Geelong Hospital.
Yes, let's hear about Happy Study.
This just makes me happy. This is why we've called it the Happy Study. So we've got a pelvic pain clinic at Geelong Hospital, and for a very long time I was trying to work out how to fund a pain psychologist because that works really well. We've got great evidence for its effectiveness, but couldn't work out how to fund it because most of psychology care is community, which means that you get a mental health care plan from your GP and that's how you access it for it to be subsidised, but it's still expensive. And, it's not like one visit fixes your life. Like it's an ongoing treatment often for some people over, 5 visits or 10 visits. So the way to fund the pelvic pain psychologist turned out to be the randomised trial that I never thought that I'd ever be involved in. And so the way that we set up the trial was that everyone gets something. There's none of this, we study you, see you later. So there's a control group who has usual biomedical approach, so hormones and surgery and that sort of approach, versus 8 weeks of online CBT in a group, which then gives you, free psychology, pain education and CBT, versus 8 weeks in a group doing yoga for pelvic pain. And so at the conclusion, the control group or the education group then gets to choose one of those other interventions.
Oh, great.
So that everyone gets something.
And is the trial still going?
Yeah, we're halfway through recruitment. It's going gangbusters. We thought it would just be Geelong, but then COVID came along and now it's anywhere you want in Australia.
Oh,
provided
great.
that your time difference means that you can get to the classes.
And what do you have to qualify for to enter the study?
You have to be over 18 and have had a previous diagnosis of endometriosis, which, harking back to the early part of this discussion, was not part of the original plan. We wanted it pelvic pain plus or minus endo. But the only way that we could get funding was that if people had had endo diagnosed, which makes me a bit sad because I'm pretty sure that we've got evidence that these things can work for people without endo and pelvic pain. Sorry, pelvic pain, no endo.
And do these women have to be not planning to have a child as well? Does it matter?
Yeah, if they get pregnant during we're not going to stop them conceiving.
Okay. Yeah.
And it's people, actually. So if you're a trans man with endo and you've got pelvic pain, you can be in the study.
Right.
So, yeah, and if you get pregnant and that's what you want, well, then good for you.
Good step forward.
We will still measure stuff.
Right.
Yeah. So other resources are the Pelvic Pain Foundation of Australia, which is a fantastic resource and really was set up again to push this idea that if you forget about muscles, there's a major aspect of your pain that will not be addressed. There is the Monash IBS website. That's really handy because if you've got one pelvic pain thing, you've probably got another pelvic pain thing. So there's lots of crossover with IBS and gut dysfunction. So that's got some good information about the low FODMAP diet, which is a good evidence-based diet that is super fiddly but really works for some people, plus gut hypnotherapy information. And we know gut hypnotherapy, believe it or not, actually you probably would believe it, but when I talk to doctors, they look at me quizzically, has great evidence, great evidence for treating IBS.
Oh, wow.
So treating comorbidities is important because, again, if pelvic pain's, 10% of your suffering and anxiety or PTSD or a sleep disorder or, gut problems are the majority, well, then you need to treat it all.
We know there's the evidence there, but clinically, are you seeing a lot of people get a lot of benefit from trying a lot of these things?
Yeah,
like yoga and
absolutely.
meditation.
Yeah. So if you can do it all to start with, it is overwhelming sometimes, but people get better faster. So we know that the longer pain lasts, the harder it is to fix. So if you do more things earlier rather than this sort of sequential monotherapy type approach, you'll get better faster because everything was always complicated. Everything was always a million variables.
And is this getting taught at medical school?
We did talk quite a bit about the biopsychosocial approach to health problems.
Yeah.
But the way that our health system funds it means that it becomes more and more difficult, particularly in the hospital system, to provide that.
Yeah.
So you've got these really competing or disincentives.
Makes it difficult.
Which is why I think I had thought for a long time that upskilling everybody was the right way to go. But I'm beginning to think that dedicated centres means that you can start properly from the beginning, and maybe then they attract different funding to whatever outpatient funding the hospital's using or MBS funding that you're using in private land. So if you start with a group at the beginning, you can set your intentions. You can say, this is what our philosophy is. These are the guidelines that we're going to follow. And we're going to start with a pain psychologist and a physio and a yoga teacher and a dietitian and a gut hypnotherapist all together from the start.
So tell us about the pain clinic at Bowen Health.
So it was set up by a physiotherapist, Hannah Grath, who is the biz. She's now in Sydney. And it was a session a month, and it was to get groups of people together, really. So it was seeing that there was a massive need in the community, women with pelvic pain who were sort of having to go between this clinic and that clinic and the other one, and it was all easier for people when they get the same message from a bunch of people all at the same time. Yeah. So it was gynae, physiotherapy, now we have urology, colorectal, a pain physician, but still no sex therapist, still no pain psychologist.
Coming.
Yeah. And so we have an intake questionnaire, and part of that is helpful because it teaches people about all of the things that matter. So we're asking questions, we're taking a history from them, but probably what partly going on is that they are learning that all of these things matter. And so they come to it in a slightly different frame of mind than if they were going to a more traditional gynecology clinic.
Yeah, interesting. Great. And so for people to access this, do they just need a referral from their GP?
And then the next thing I would say is that often the stuff that I do in that pelvic pain clinic is primary care that could have happened in many other ways in their community already with fabulous GP care and use of hormones and fixing asleep and them organised. So, it does start with the GP to coordinate care. They are the ones who can help with allied healthcare plans or the chronic disease management plan to help fund dietitian or whatever, get the psychologist, draw it all together and manage it. But again, GPs are under the pump, and particularly for the last 2 years, they've been doing COVID stuff.
They have to be across everything. So sometimes it can be difficult.
Yeah, so maybe we had originally hoped that our role would be assessment, to say, here, you've had your one visit, here are all the things that we think matter. Now, off you go and implement them. And sometimes that works and sometimes it doesn't. So there's been lots of talk in the media from politicians over the last couple of years about, go see your GP. But lots of young people don't have the same one GP. They'll see this person for that. They'll see that person for their swab that they needed, after whatever. It's not as organised as we would love it to be.
And I feel like that's where a lot of women feel the most let down, that first step. Felt like they weren't heard or they felt like they didn't get their proper referrals. But yeah, GPs have a big job.
But so yeah, it is interesting. So often the GP has told them everything that I then reiterate and confirm. And I think I know that it is different coming from someone who can do some fancy surgery. So I'm telling them exactly the same things, that all these things matter. And so maybe it's a different person telling them the same thing. Maybe it's just an accumulation of lots of people telling you that same message. Eventually, then that seems to stick better. But lots of this is primary care. And so, we've got heaps of GPs who've done O&G training in Australia. They're an absolute force. And from a gynae point of view, I only see the ones that they didn't get better. So the population that specialists see are quite a biased sample. There's a whole heap of really good stuff happening out there with women's health GPs.
I think we've covered everything. Is there anything else you feel like we need to cover?
Yes. If someone is planning their career, we really need more pain psychologists because
Absolutely.
lots of
There's only a couple in Geelong, isn't there?
yes, yeah. So lots of the pain courses at universities do not incorporate any pain neuroscience. Did I say that right? Most of the psychology courses in Australia do not teach people about pain.
Wow,
And,
that is really surprising.
1 in 5 Australian has chronic pain, and we know psychology improves that. What are we doing? Career opportunity, fantastic. I would love some research about food and endometriosis and pelvic pain. So the Food and Mood Centre at Deakin did this great study on depression and what you eat, and they demonstrated that their food decreased depression. So it had a treatment effect compared to, here's the Australian food pyramid, here's a dietitian, we'll help you follow that one. I would love to do that for food and pain associated with endo.
Amazing.
Yep. So if anyone's, twiddling their thumbs working out what they want to do their PhD on, that would be a winner. A lot of emergency department presentations, we're not very good at fixing pelvic pain, acute on chronic pelvic pain when people present to emerge. I would love some new treatments for that. That would be fantastic.
Yeah, absolutely.
So there's lots of research to be done and lots of work to be getting on with.
Absolutely.
It's a good space.
Thank you so much for coming today and speaking to us.
That's all right. I could talk about this for years.
I think we covered a lot, so it's great. Thank you.
My pleasure. Thanks for the opportunity.
Thank you for listening. If you enjoyed today's episode, please share it with a friend, subscribe where you listen, or head to Apple to rate and review. You will find the show notes on our website, conceivethepodcast.com.au, and can follow us on Instagram at conceive_podcast, where you can also leave questions for future episodes.